Hello and welcome to our third webinar in Genomics of Kidney Disease series. I'm most delighted to introduce to you our content expert today, Dr. Mireille El Ters. Dr. El Ters will be sharing with us her knowledge about the value of genetic testing in transplant nephrology. Dr. El Ters completed her medical school training in Lebanese University in Lebanon and her internal medicine training at St. Louis University School of Medicine. And I was lucky to be her co-fellow during nephrology fellowship at Mayo Clinic in Rochester. She's currently an assistant professor of medicine at Mayo Clinic in Rochester. I should share with you that she was the recipient of the Transplant Scholarly Award in 2019 to study genetic mutation in kidney transplant recipients with FSGS. And she was also the recipient of the Robert Falk Career Development Award in July of 2020. Dr. El Ters, we are so delighted to have you today and excited to learn from you. Welcome. So we'll start us off by telling us a little bit about you and your current practice and how you got interested in pursuing genetic testing for your patients.
Thank you very much, Dr. Keddis, for the kind introduction. It's my pleasure to discuss today genetic consideration for transplant nephrology practice. So my interest started primarily because I have a special interest in glomerular diseases that can recur after transplant, and in particular with FSGS. And over the past several years, there has been advances in our understanding of the underlying genetic causes of kidney disease, including FSGS, and how that could impact our management before transplant, around the time of transplant, and post-transplant. And I'd like to convince you with my talk today that genetic testing plays an important role in the transplant evaluation of those patients.
Wonderful. I think I'm already convinced and I haven't even started yet. So tell us a little bit about, as a transplant nephrologist, why is this relevant for your patients?
Okay, excellent. So I want to start by an introduction in general about the impact of glomerular disease in transplant. So we know that recurrent glomerular diseases are increasingly recognized as a major cause of graft loss long-term. And among those, one feared complication is the recurrence of FSGS, which can occur early on or many years to months later. And it's thought to be related to a circulating factor in the patient's system that is toxic to the podocyte. But despite having had extensive research done, we have not yet identified that factor. And so as you can see here, the risk of losing a graft in case of a recurrence of FSGS is almost fivefold than in those who have not recurred. And when we think of FSGS, really this is a term describing a lesion on the kidney biopsy of a scar. It's really not a diagnosis. And our role as nephrologists, and especially in the transplant clinic, is to really understand the cause of FSGS and be able to classify it correctly. And when we think of FSGS, we think of two broad categories. The primary form, which is the form that we fear the most after transplant that can recur, and then all secondary forms, which could be related to a variety of factors, for example, being born with a lower number of nephron from renal agenesis, or low birth weight, prematurity, or having an abnormal stress on the kidney from morbid obesity, reflux nephropathy, nephrectomy. Viral forms of FSGS or drug-induced form of FSGS exist. And then finally, the area that I want to focus on is the genetic forms of FSGS, which the knowledge has expanded significantly over the past several years in that regard. And so it is, again, part of our job, especially in transplant clinic, to understand what are the factors that are clinically associated with high risk of recurrence, and essentially correctly identify those who have the primary form of FSGS. And we currently rely primarily on clinical parameters such as younger age diagnosis of FSGS, presenting with nephrotic syndrome, which is a key clinical history to obtain, hypoalbuminemia, severe proteinuria or edema, a rapid progression from diagnosis to end-stage renal disease. Unfortunately, one of the most reliable risk factors is having recurred in a prior kidney transplant, which places a person at almost 80% chance of recurring again. Now, importantly here is that genetic forms of FSGS, with very few exceptions, are associated with a low risk of recurrence, hence the link that I wanted to talk about. Now, how do we treat FSGS if it recurs? Essentially, right now, the main treatment is plasmapheresis and rituximab, which has shown benefit post-transplant in controlling the recurrence, but also has been used pre-transplant in several centers as part of a kind of an empiric clinical protocol in order to try and prevent the recurrence. And currently, there is an ongoing multi-center trial that is funded by the DoD looking at specifically the question of whether rituximab and plasmapheresis is helpful in preventing FSGS recurrence in a randomized fashion. But today, the outcome of such therapy remains unpredictable. And so the implication with FSGS classification is very important because we rely on integrating the clinical history, the laboratory testing, kidney biopsy, and in a certain subset of patient, genetic testing plays a role in helping us classify FSGS, because a correct classification has implication on appropriately counseling patient on their risk of recurrence, risk of graft loss, but also appropriately enrolling them in trial if we believe that they do have a primary FSGS. And so shifting gear to what do we actually know about the genetic data in chronic kidney disease in general, but also in FSGS. So this is one of the seminal studies that was published end of 2018, which looked at over 3,000 patients with different forms of chronic kidney disease. And what they found is that after polycystic kidney disease, the most common mutation were found in the collagen genes. So the collagen, which we think about as causing Alport syndrome. But importantly, if you look at this figure, what it shows is that the clinical presentation of most of those patients was actually that of a glomerular disease rather than a typical Alport presentation. And so the utility in that study was demonstrated by the fact that in 18 patients, they were able to reclassify the disease from an FSGS into a collagen-related nephropathy. And that has helped in disfavoring immunosuppression among patients who were found to have genetic or monogenic forms of FSGS. Now, in a study that specifically looked at just adult patients with FSGS diagnosis, they have looked at 193 such patients, and their yield for a genetic mutation in that study was 20% for either definitely pathogenic or likely pathogenic mutation. And interestingly, even when they looked at an expanded gene panel, collagen 4 mutation disorders were again the leading monogenic cause of adult diagnosed with FSGS, and not podocyte gene or other genes. What is the implication on kidney transplant and beyond? So the first observation they made is that none of the patients who had a genetic form of FSGS responded to immunosuppression with a complete remission, which makes sense. And this is an important point here to make, is that 100% of patients who had the collagen mutation had more than 50% podocyte foot process effacement on electron microscopy. And this is a key point because the thought has always been, in theory, that if you have diffuse foot process effacement, that's a sign of a primary FSGS. And then finally, and a very important implication here is that 0% of those patients recurred after a kidney transplant. Now, in another study that looked at adults that were on the waiting list for a kidney transplant with an undetermined cause of kidney disease, they were able to identify 57 such patients. And of those, they were able to reclassify or recognize an underlying genetic cause in 6 out of those 57, so roughly about 10%. And the majority of those patients, again, about 3 of those had collagen mutation recognized or identified. And so the conclusion was that the genetic testing would provide a molecular diagnosis with some of the patients that have undetermined end-stage renal disease prior to kidney transplant. So shifting gear a little bit to talk about Alport syndrome, since it's been recognized as an important a mutation in those patients. So Alport syndrome is a primary basement membrane disorder arising from mutation in the genes of several members of the type 4 collagen family, the alpha 3, 4, and 5, forming the glomerular basement membrane. And so when it is mutated, it will lead to an abnormal architecture of that glomerular basement membrane. Now, the typical presentation that we learn in textbook is a person who has kidney failure with hematuria, a varying degree of proteinuria, hearing and vision impairment, and on the kidney biopsy, you will see those typical features. There is currently no specific therapy, and most of those patients progress to requiring a transplant. Now, the mode of inheritance of these is primarily an X-linked mutation of the collagen 4A5, which is the most common, anywhere from 2/3 to 80%, followed by collagen 4A3 and A4. And rarely you can have multiple mutations together. Now, it is important, however, to recognize that not everyone with Alport or collagen mutation presents the same way, and there is quite a bit of variability that can be seen depending on the person's gender and the kind of mutation that they have. For example, in X-linked Alport syndrome, a woman who is a carrier of the X-linked mutation may develop end-stage renal disease but at a much later time in life, at a median age of 25 and an incidence of 30%, versus a male who is a carrier of an X-linked mutation would develop end-stage renal disease at a median age of 25 with an incidence of 90%. And that has to do with a phenomenon called lionization, where you can have variable inactivation of an X chromosome in women. In autosomal recessive form, even carrier states might rarely develop end-stage renal disease in about 17% of the cases at a later time and age. And with autosomal dominant forms, because of different penetrance, you may have a variable degree of involvement and a more progressive form of kidney disease. And importantly, there's been studies looking at families, and even within the same family, there's variability with presentation. So what that means, the point here is that you cannot really rule out a diagnosis of Alport based on a person's clinical presentation, especially if they are presenting at a young age to you. And that would be relevant for our biologically related donors that would like to be evaluated for someone who has or is suspected to have Alport. Now, what do we know about implication on kidney donation? There's limited data that exists already there's a series of women, mothers, who are known to have are carriers of the X-linked Alport that have donated to their children. And what that series shows is that there's an increased risk of proteinuria, hypertension, and a decline in kidney function up to 60% 14 years post-donation. So the current KDIGO guidelines advise that female carriers of an X-linked Alport syndrome should be discouraged from donating.
Wow, that was really powerful. I learned so much already. Looks like there's a lot of collagen abnormalities as we talk about FSGS and as we talk about Alports. Can you summarize for us, Dr. El Ters, if I was a transplant nephrologist and you alluded to which characteristics we should be thinking about: young age, nephrotic syndrome, and uncharacterized FSGS, what patient populations should we keep in mind as we consider who we should refer for genetic testing in our transplant clinic?
That's an excellent question. So in my mind, when I think of what are the key categories of patients that I would consider genetic testing, the first category is those FSGS patients, and I'll have a second slide that specifically talks about who within the FSGS patients you would consider that. But the key point with FSGS is you want to identify a secondary genetic form so that you avoid the harm of interventions such as preconditioning before transplant and correctly identify the risk of recurrence. But the second category is the patients who you present with unknown cause of end-stage kidney disease. And we all see those patients where they would show up, they have never been seen before, their kidneys are shrunken, we cannot do a kidney biopsy. This is of relevance, especially if they have a positive family history of kidney disease and also if they're younger. Another category that I think about are those patients with chronic tubulointerstitial disease, especially if they are young and if you cannot recognize a secondary cause, like a clear-cut medication-induced interstitial nephritis or an autoimmune form or reflux. You may be able to recognize specific conditions that are causing autosomal dominant tubulointerstitial disease. And then another category is someone that you know has Alport. Let's say you have a very high suspicion of Alport. They have all the classical features. They have even potentially a kidney biopsy showing that. But it's important to be able to recognize which mutation they have if they have a biologically related donor. Because as I explained before, if you have someone with Alport that want, for example, their brother who's 10 years younger to donate, or their sister, you're not going to be able to rule that out clinically. And if you have a molecular diagnosis of a certain gene mutation, you can screen the donor for that mutation and rule that out and be confident that they can donate safely. An important point I want to make is that genetic testing is not meant to exclude a patient from transplant. Some recipient expressed that worry that I don't want to do a genetic testing because you're going to deny me. That should not impact really the decision on candidacy. It's used to help us plan and help us screen donors and not exclude any recipient. So as I said, who are the potential patients with FSGS that I would consider doing genetic testing on? If you have someone who presented with what looks like a primary FSGS, they had nephrotic syndrome, edema, hypoalbuminemia, but never responded to any immunosuppressive therapy, there are a subset of those patients that have underlying genetic conditions. And then patients who have FSGS that appears to be a secondary process, so no nephrotic syndrome, no diffuse foot process effacement, but you don't identify any clear cause from their history that you can gather. And then finally, FSGS, where you see a discordance between how they presented. For example, they had no nephrotic syndrome, but their biopsy shows diffuse foot process effacement, which, as we saw, can be seen in collagen mutations. Or if you find some atypical features on the biopsy, such as thin basement membrane, and you don't have a good explanation, or they have hematuria. Those would be, in my mind, the categories of FSGS I would test. If you have someone who had a primary FSGS, was on steroid, had a response, then relapse, was on tacrolimus and had a response, then relapse, those are not, you will not likely find any underlying genetic cause in those patients that have had response to immunosuppression. And those would be a category I would not advocate to test. So I would like to share our experience with what we've done over the past couple of years, utilizing genetic testing in our kidney transplant clinic. So we've had selected candidates, as we discussed from the prior two slides, where we tested them with a comprehensive renal panel that has over 340 genes that looked at different kidney diseases. And specifically, if we had a high suspicion for a tubulointerstitial disease and our panel of 344 genes were negative, we have sent out a test that can only be done at the Broad Institute for MUC1, and that is sent via help from Wake Forest University. And so when we get that result, we have a nephrology genomic board that is a multidisciplinary committee made of nephrologists that have interest in genetics, renal pathologists, medical geneticists, PhD experts in genetics, as well as genetic counselor. We meet every month and sometimes twice a month to review the cases, discuss the clinical presentation, pathology, as well as the genetic result, and essentially come up with a recommendation for the patient on the implication of those testing. And so we had a total of 34 panels sent. 4 had to be canceled because of cost and a patient rescinding consent. Of those, we had 13 that out of 30 that were found to have a genetic diagnosis, so pathogenic or likely pathogenic variant. 6 that had a completely negative mutation testing, and 11 that had an unknown variant of an unknown significance. And I'll touch on that later a little bit more. Now, our initial average waiting time between the test and the result was 68 days, but I'm happy to share that I looked at that more recently and our number have gone down a little bit to 49 days, and we're hoping to bring it down further. So, but we had about essentially 43% rate of a genetic diagnosis. When we look at the candidates that we have tested 30 recipient candidates and 5 of their donors. Their average age at the time of kidney diagnosis was 27. Most of our population is Caucasian in Rochester. Half of the patient, 50%, had a positive family history of kidney disease. And again, our percentage positive testing rate was 43%. Now, when we try to compare those with positive versus negative results, can you tell from their clinical presentation? And what we found is there is no difference in terms of their age at presentation, for the evaluation, age of the kidney disease diagnosis, the phenotypic presentation, the gender, race. But the only important characteristic difference was that those who tested positive had a positive family history in about 77% of the cases versus 29% of the cases in those with negative results. Now, most of the patients that we have tested presented with Fsgs on their biopsy, so 24 out of 30, and then the remainder were unknown in 10% of the cases, tubulointerstitial nephritis, and then one young patient with extensive nephrolithiasis. And as consistent with the other studies that we have discussed before, the majority or the most common mutation, again, was that of a collagen mutation in over 50% of the cases. Now, when we look only at the FSGS cases, we had 24 patients that were evaluated. 10 of those had a pathogenic or likely pathogenic variant, so our yield was about 42%. 7 of those 10 were actually collagen mutations. So this led us to reclassify 29% of patients from being called FSGS to Alport Syndrome. And what is the clinical implication of that result? Is that one, we were able to refer patients for extrarenal manifestation. We recommended targeted testing of family members interested in donating. We also counseled the patient that they have low risk of recurrence of FSGS, and as such, we recommended avoidance of any kind of pre-treatment with rituximab plasmapheresis. And then, of course, it has implication on enrolling patients in clinical trial because they would not qualify to be enrolled in a clinical trial for primary FSGS.
Thank you, Dr. El Ters. I think earlier you had mentioned that the initial turnaround time was 4 to 6 weeks, correct? And then the most updated follow-up was 49 days.
Yeah, I mean, it's still, so it was 68 days and then it went down now, our median to 49, but I think it's still skewed by those earlier longer time. We're aiming now for about 2 to 3 weeks turnaround time.
Wonderful.
Yeah.
Would you share with us, Dr. El Ters, some representative cases from your clinic where you utilized genetic testing and impacted your patient care?
Yes, for sure. So I want to start. This is actually the very first case that I sent genetic testing on. I changed the age a little bit so that for confidentiality, but we have a young Caucasian patient that presented for second opinion to our center. Her case was felt to be too high risk in the local transplant center, and the main question for us was whether she needs preconditioning for her diagnosis. So her history, she recalls being told she was hypertensive at age 13. No workup was done at that time, and then she presented, and found to have proteinuria while pregnant at age 26, and that proteinuria persisted. So she underwent a kidney biopsy and was diagnosed at that time with a primary FSGS, and started on treatment with prednisone and tacrolimus, which she took for 8 years with a progressive decline in kidney function. When you look at her outside laboratory testing, you notice that the serum albumin has mostly been in the normal range, no real hypoalbuminemia, variable degrees of proteinuria on her urine ranging from subnephrotic to slightly nephrotic, and then persistent microscopic hematuria was noted. And this is her biopsy. These are the actual slides that we obtained. And as you can see in A, there's a clear FSGS lesion on the light microscopy. And when you look at the glomerular basement membrane and the podocyte, there is a diffuse foot process effacement. And the comment, this is from the report that was obtained, was that the presence of diffuse visceral epithelial cell foot process effacement is suggestive of a primary FSGS. Now, they do note that the glomerular basement membrane were thin, but they also note that there's no features of Alport identified. So her family history is very kind of vague, and that's unfortunately also common in our practice. She recalls that her father had kidney fracture, this is quoted, and that he needed his kidney removed but did not develop any kidney disease later in life. Another cousin also had nephrectomy. And importantly, she had a sister that is healthy, slightly younger than her, that wanted to donate and had what appeared to be a normal donor evaluation, but had a positive dipstick for blood on the urine with negative urine microscopy, so no RBC. So given the uncertainties with this case and kind of the atypical features, we proceeded with genetic testing. And this is the result that we obtained. So the patient had a likely pathogenic variant in the collagen 4A3, which in this case is an autosomal dominant variant. And we then went back, and our genomic renal pathologist, Dr. Cornell, went back into her biopsy slides and looked deeper and was able to identify areas on EM that showed lamellation and scalloping that is consistent with Alport syndrome. So the pathology was amended to essentially correct the diagnosis to a glomerulopathy consistent with Alport syndrome. Now, what were the implications for this patient? The main implication and the reason she was sent to us is because to identify or see if she qualifies for pretreatment, and we reassured the patient that she's at low risk for recurrence, does not require any kind of preconditioning, and unfortunately, in retrospect, she had received many years of unneeded and potentially harmful immunosuppressive therapy. We had referred her for genetic counseling and screening for extrarenal manifestation. Her sister, who wanted to donate, was assessed for the similar mutation and found actually to be a carrier and was excluded as a donor. And I do want to note that the sister did go through a thorough donor evaluation that was otherwise completely unremarkable, including iothalamate clearance, 24-hour urine protein, ambulatory blood pressure monitor. So this was that first case. I want to show another case of a gentleman in their mid-50s presenting for transplant evaluation. Their history was that of a long-standing proteinuria, microscopic hematuria since he was a teenager, and that was reported as part of a routine screening. He never really had any nephrotic syndrome. He recalls having a kidney biopsy done over 20 years ago and essentially had shown non-specific scarring. Unfortunately, it was too old for us to get the slides, and there was really no clear-cut diagnosis made. But the patient never had nephrotic syndrome, was never treated with any immunosuppressive, and really had a very progressive loss of kidney function. Interestingly, he shares with me, and I always specifically ask patients that question, that he has hearing loss, but he thinks it has to do with the fact that he bartended as a young man. And essentially, he was interested in a preemptive kidney transplant, now at stage 4 of chronic kidney disease, and specifically his daughter is interested in donating. His family history is notable that he had a brother who suddenly passed away from malignant hypertension in his early 40s, and an autopsy showed chronic kidney disease, but no specific diagnosis was made. So based again on the clinical presentation with hematuria, proteinuria, family history, hearing loss, my main suspicion was for an Alport syndrome. But again, we do not have an actual diagnosis made. And so the genetic testing here was very helpful. He underwent a genetic testing, which showed a likely pathogenic variant in the collagen 4A5, which is again the most common mutation that you see with Alport syndrome. The implication of this test, key implication here is this is an X-linked inheritance, and his daughter is an obligate carrier since she must have received the X from him. And as such, she was discouraged from even being considered as a potential donor. So she did not get a donor evaluation. He ultimately ended up with a living unrelated transplant and is doing well. The third case I want to highlight, is a male in his late 60s presented with chronic kidney disease stage 5. He had a biopsy proven Fsgs, but with mild to moderate foot process effacement, glomerulomegaly, a lot of globally sclerotic glomeruli, with no associated nephrotic syndrome. So essentially what appears clinically to be a secondary Fsgs. And this was felt to be secondary to obesity and smoking. He had a few cysts on his kidney, microscopic hematuria, and again, he had a daughter that is interested in donating. Given that there was no clear, very obvious cause of the secondary Fsgs, we proceeded with a genetic testing. And in this case, we actually identify a gene that has been linked to Fsgs. However, the mutation or the variant that we identified in his case was a variant of uncertain significance. And the recommendation from the genetic laboratory was that as those results are not diagnostic, the individual and at-risk relative should receive clinical evaluation, and the predictive testing of variant is not clear and not recommended for family member. Pretty much the recommendation was not to test the family member for this variant. And so this last case highlights some of the challenges with genetic testing, because it's not black and white all the time. You could have a pathogenic or likely pathogenic variant that clearly explains the kidney disease, and that gives you your solution. You can have a completely negative genetic testing, which at least tells you, as far as the knowledge that we have these days, this is, there is no underlying mutation that we can identify. But in between, you can have variants of uncertain significance, meaning you're finding a variation in the genetics of those genes that you're testing, but we currently don't know whether they are of any clinical significance or whether they're going to be associated with a genetic disorder. And in the world of genomics, and I'm sure my colleagues who are more into the basics genetics have discussed that or will, there's really a spectrum of clinical significance. So on the one hand, you have the clearly pathogenic cases where you've identified a mutation that alters the gene, alters the protein expression, and causes the disease. Or on the other spectrum, you have a clearly negative panel where everything kind of fits with the normal human phenotype. But then in between, you could have kind of a likely benign, likely pathogenic variant of uncertain significance. And you can end up in that kind of middle ground where you really don't know yet. And the geneticists rely on guidelines, standards and guidelines that were published in 2015, and they rely on a lot of parameters that I won't get into here to kind of define a variant as pathogenic, benign, or VUS. But what the bottom line for us is it highlights the importance of having that support from the geneticist to explain to us what these results really mean. And so in this case, we've discussed the case extensively in the genomic board with the help of our medical geneticists, counselors, and the variant that we discovered was not thought to explain the kidney disease. And the final recommendation was not to test the donor. An informed discussion occurred with the donor, the prospective donor, and about the unknown nature of this variant, and she agreed after informed consent to proceed with donating. The implantation kidney biopsy, which we do on all recipients, which is pretty much essentially a donor biopsy, showed normal glomeruli. A 6 months follow-up showed excellent GFR in the donor, normal blood pressure, and no proteinuria. So these are my 3 cases that I wanted to highlight.
Thank you so much, Dr. El Ters, and I especially appreciate you showing a case where the outcome of the test did not necessarily change what you did because of some of the inherent challenges of what you do with those unknown variants. And that's part of the reality of genetic testing in general. You alluded earlier to testing some donors. You tested this daughter with the patient with excellent Alports. Can you tell us a little bit in general, when do you consider genetic testing for donors, and how do you approach that?
Yeah, that's a very good question. I think the answer is probably the simplest here, because we really recommend testing donors only if the recipient that is biologically related to them is found to have a variant that clearly explains the underlying kidney disease. And so, why is that important? You do not want to take a donor that is by definition healthy with no clinical manifestation of any disease and then just run a panel of over 340 genes on them or more, because there's always a risk, and that happens, of getting a variant of uncertain significance, or even sometimes there's been studies that shown if you just take patients and just run indiscriminately take healthy people, there's about 1% of them that would have a pathogenic variant. But because of the fact that they're healthy, you don't really have a correlation that could tell you whether this variant of uncertain significance that you find is of any relevance. And so your positive predictive value would go down and your confidence in the result will be low. So really my recommendation is always start the genetic evaluation with the recipient that has the actual disease. If you find a variant that explains their disease, only test their biologically related donor for that specific variant only. That would save time, that would save cost, that would also save all the anxiety that arise from some results that are unexplained.
Thank you, Dr. El Ters. I can imagine probably most patients wouldn't want to know just for the sake of knowing, especially if it impacts their life, anxiety, and their career, for example. What about APOL1? There's so much talk about APOL1, both for recipients and donors, and a lot of controversy about what you do and how you manage that. Can you spend a little bit of time on that for us?
Yeah, for sure. So this is a topic, it's a very hot topic. It's been a hot topic for several years now, and a topic of controversy too. So we know from observation that African Americans have higher rate of kidney disease than European American. And in a landmark study, two independent sequence variants of the APOL1 gene, which are the G1 and G2 variant, were found on chromosome 22 that confers an increased risk of FSGS among other forms of kidney disease, primarily non-diabetic kidney disease in African American. And those two APOL1 are common in African chromosome, but absent in European chromosome. And they're primarily in West Africa, African American, but also Afro-Caribbean. And that's an important key information here to have. Now, what is the impact on long-term allograft survival? These are two studies done looking at initial one at 675 kidney transplanted from deceased donor who have the APOL1 high-risk genotype, and that is by definition means you have two of those alleles, not just one. So if you have 0 or 1 allele, you're considered low risk. You have to have both variants to be considered high risk. And what you can see here is that there's an increased risk of allograft failure 2 times in those who have the high risk allele. And that result remained when the study was expanded to over 1,100 deceased donor kidney transplant. Now, however, this study did not include living donor kidney transplant. We also know from observation from very high quality studies that live kidney donors of African ancestry have a higher risk of developing end-stage renal disease than demographically matched non-donor. And in a relatively small study of 136 African American donors, those with the 2 APOL1 variant started out with a lower GFR before donating and ended up with a lower GFR after donating. And the slope of GFR loss after donation was steeper among those with the 2 high-risk allele versus the 0 or 1. Of those 19 patients, 2 ended up developing end-stage kidney disease. Again, however, this is a very small study, and most of the patients with 2 APOL1 risk variant do not develop end-stage kidney disease. And so we know that there's second hit or other modifiable risk factors such as obesity, hypertension, viral infection that can initiate the kidney disease. And there's really several ethical issues concerning use of genetic testing to determine donor eligibility in this population. And as such, there's currently an ongoing multi-center prospective study called Apollo, looking to understand the impact of APOL1 high-risk allele on long-term kidney function for donors and recipient outcome. And so this is going to take several years. Meanwhile, recently, as of January of 2021, there is a work group in the American Society of Transplantation called the ApoL1 work group that has proposed some guidelines for us to use in potential donors and how to assess potential donors who self-report with African ancestry. And that includes African American, Afro-Caribbean, Hispanics, and Africans from West Africa. So all these donors should be informed about the presence or the availability of ApoL1 gene testing and what we know about the risk of end-stage kidney disease. And those who have other known independent risk factor for end-stage kidney disease should be considered for testing. And they define that as being younger, less than 44, male, smoker, obesity more than 30, hypertension, low normal GFR 90 to 99, a family history of end-stage kidney disease or hypertension or diabetes in a first-degree relative. If you deem that the test is appropriate, it should only be offered to candidates after they've passed their preliminary medical and psychosocial evaluation, and should only be offered after appropriately counseling those potential donors. And if they wish to donate regardless of their genetic testing result, then they should be allowed to proceed if otherwise their clinical parameters does not exceed the acceptable threshold for transplant. So if they have otherwise a normal evaluation. The key to keep in mind is the hazard risk of 2 for graft loss does not exceed other potentially acceptable risk factors, such as having sickle cell trait or having a mild impaired glucose tolerance. So transplant programs should address with the patient, with the prospective donor, the pros and cons of the ApoL1 and the lack of robust data. And they should explain to the prospective donor that there's ongoing study to better understand that. And essentially, the bottom line is you cannot force a donor to undergo the testing, and you should not use that only factor as the one excluding factor for donating.
So Dr. El Ters, in your experience, when you offer ApoL1 testing, how many of your potential donors say yes?
So I want to just preface by saying we do not have a big population of African American donors, but the ones I've approached with that have agreed and would like to know, because they are also concerned, obviously, about their risk. I did have a patient that did not wish to know and was going to donate regardless. And so that there are situations like that. And you have to look at each person specifically and not just outright recommend it on everyone.
And from your knowledge, has there been any discussion about assessing donor perception about ApoL1 and how that impacts them?
Yes, there's been studies done, that surveys to African American, where most of the patient actually would like to know their status, but they don't necessarily take that knowledge to mean that they would not donate. They may still wish to donate, but the majority of donors would like to know that information.
So it sounds like we already have some ongoing, maybe not challenges, but opportunities. And hopefully we'll learn more in the next 5 to 10 years. Can you reflect with us about current challenges that you see in your day-to-day care of your patients? And perhaps where do you see the landscape changing in transplant nephrology in general and with genetic testing?
Yeah, thank you for this question. I would say one of the first challenges, or some of the challenges we face, is logistics. So the cost is a big one. Whether insurance pays for it or not is an issue. The cost of the genetic testing themselves can be very variable, but is tending to improve as we have better technology. The second issue is the turnaround time. Depending on the kind of genetic testing you are requesting, it can take several weeks to months. More focused testing, such as what I advocate for donors, can take a couple of weeks. But larger panels can take longer. You have to also add the time needed to get the approval from insurance, and time is of essence in those transplant evaluation, especially for those trying to get a preemptive transplant. So that has to be kept in mind. Another big challenge is how do you interpret variants of uncertain significance when they arise, as I showed you in one of the cases. Do you test donors for that? Most of the time the answer is no, but it's not always straightforward. So that's why it's always important, again, to get that multidisciplinary feedback and careful review. And then finally, such as what we saw with the APOL1, there's ethical questions about testing, doing genetic testing in general, especially in healthy individual wanting to donate, and kind of recognizing some of the the question of insurability, the question of the uncertainty of what that mutation that you'll find really means for that person lifelong. And so beyond that, I think also if we look kind of deeper, there's unease in the nephrology community of using the genetic testing. There's enthusiasm, but there's also unease because we really don't have a good training, or at least historically, in terms of the genetics during our nephrology training, including what test to select appropriately, knowing the different techniques and their limitation and benefit, accurately interpreting inconclusive results such as variant of uncertain significance. And that leads us to having difficulty with post-test counseling of patients on both the renal and extra-renal implication. So I think today in the community, it's becoming relatively easy or easier to request a genetic test. The big problem is, how do you counsel patient before? And more importantly, how do you counsel them after you get the result, which I sometimes see results with 10 different variants of uncertain significance. It becomes overwhelming really to interpret as a nephrologist. So in a recent survey among Australian nephrologists, despite most clinicians, 85% thinking that genetic testing is useful, only 23% indicate that they are confident to use that result in their practice. And the preferred model among clinicians was a multidisciplinary renal genetics clinic, which is essentially what we have here at Mayo since 2018. We meet once every month, sometimes twice a month, and we review all the cases with our pathologist, nephrologist, medical genetics. And then this is in collaboration with the Center for Individualized Medicine that provides the support, technical support, and genetic counselor support. And more recently, we've collaborated with them on the specific kidney transplant program, where we created a genomic panel that is focused in recipient with suspected kidney disease. And we created a panel that is more focused, it's more time efficient and cost effective. And we've incorporated the use of the genetic testing unit in the transplant evaluation. So essentially the flow that we have been following ideally is a patient shows up in transplant clinic, there's an identification of possible genetic cause, we refer them to the genetic counselor, that counsel helps us with counseling the patient on the risk and benefit of the test, working on the paperwork, submitting the actual test, and following up on the result. Once we have that result, we do review in the nephrology genomic board. And once we have a final recommendation, the genetic counselor as well as transplant nephrologist reviews those results with our transplant patient. If there's a positive result and there's a biologically related donor, then a focused gene testing of the donor occurs. And this is in the goal of having a time-efficient, cost-effective process that achieves the goals of transplant and provides that genetic counseling before and after the test. And so in general, what I found is that genetic testing has provided us with valuable information to allow us more accurate estimation of the risk of recurrence post-transplant, helping counseling and screening of potential blood-related donor. But the success of such program relies on having a multidisciplinary team approach with expertise from medical genetics, basic scientists, renal pathologists, and a genetic counselor support.
Thank you, Dr. El Ters. That was just fantastic. And I'm hoping that through this webinar, we are breaking that cycle of understanding what to look for. So educating our workforce of the future, our colleagues, how do you think about, when do you think about genetic testing? What characteristics should be in your mind as you evaluate your patients? And I recognize the road is still rocky ahead as we figure out how do we provide these services to colleagues outside of Mayo, where we don't have this model present. How do we collaborate with genetic counselors in the community, perhaps, to be able to make this a reality for others? So we've got four minutes left. I don't see any questions. I think I've asked a few throughout. So I appreciate you. Thank you for taking the time. And this was so good. So be prepared to give us some more talks in the future, and have a wonderful day, everyone. Keep in mind, we have 3 more in our Genomics of Kidney Disease webinars coming up. Next one will be with Dr. Liskey. We'll talk about kidney stones and the value of genetic testing there. And then we'll have a perspective from our genetic counselors, which will be really profound. And I hope you'll be able to join us. And we'll end it with Dr. Zan talking to us about glomerular diseases. Thank you and have a wonderful day.
Thank you very much. Bye.